Okay, guys, good morning. All right, so today we're going to talk about changes to hematological function, but we're going to start today with first talking about changes to erythrocyte function. So, quick reminder, some of the important things about red blood cells as it relates to structure and function and its production, right? So we can identify potential sources of breakdown if we know what they're supposed to do in the first place. So remember, structurally, we need a couple of things in order for our red blood cells to function well. We need the production of hemoglobin and we need iron. Okay, hemoglobin, remember, is a protein. This protein is quite large. It's in several subunits. All subunits need to be produced, and we need to make sure that we have adequate iron to support the production of hemoglobin. Okay, so that was just a key thing that I think is an important takeaway before we discuss what happens when we don't have enough of them or they're not put together correctly. Functionally, we want to remember what your red blood cell is supposed to do, right? So its structure lends itself to its function, which is to transport oxygen and a little bit of carbon dioxide, but most of us would identify red blood cells as the main transport system for oxygen. So again, if the function breaks down, we can obviously kind of come to the conclusion there's going to be an issue with the way that, or the amount of oxygen that's being transported. And then the last thing is its production. Okay, so we want to keep in mind where your red blood cells are coming from and then some unique features about them versus other cell types. So again, the production, they are derived from a stem cell that's found in the bone marrow. This is a hematopoietic stem cell which allows for the production of all the formed elements of blood, red blood cells included. That is the bone marrow in question. It is the red bone marrow, not the yellow bone marrow. So then obviously to make sure we have an adequate supply of red blood cells, you need the bone marrow to be intact. One of the kind of unique features about red blood cells that other cells they don't have, right, is there's no nucleus involved in your red blood cells, so they can't go through mitosis. So you're very heavily dependent on a constant production of red blood cells because once they're formed, they have a finite lifespan and then they're broken down. The cells that have a nucleus, we wouldn't have to rely so heavily per se on production. Okay, so now that we have that in mind, let's talk about changes to erythrocyte function. So we're going to center the conversation around anemia. Okay, there are different types of anemia. Some are genetic, some are dietary in nature. So I'm going to talk about it very broadly first and just kind of some common causes and some common outcomes you would see generally for anemia. And then we're going to break down a few different types. We're not going to discuss every single type of anemia, just a few dietary types, a genetic type, and then we'll talk about some kind of outlier types of anemia. So when someone has anemia, that means that they have a reduced, and this is really general, but that's okay, a reduced oxygen carrying capacity. So in general, we would say that the overall ability to carry oxygen in the circulatory system has been reduced. Now we're not saying why, okay, that's happening, we're just saying it's been reduced. The why would kind of draw us into what type of anemia we're dealing with. So the common causes we could kind of guess would be things like blood loss could lead to temporary anemia. Impaired production could lead to anemia. All right, so if someone had blood loss, all right, whether it be large scale or not so large scale, could lead to temporary anemia. If you have an impairment in the way the red blood cells are produced, maybe there's something with the bone marrow, maybe there's a change to erythropoietin, then that's going to compromise the ability for your patients to carry oxygen as well. Maybe there's an overall decrease in erythrocyte production, right? Maybe the hormone erythropoietin is not being produced correctly and acting in the way that it's supposed to. So there's a lot of reasons why we could identify why someone has anemia. So what are some of the more common outcomes that we could discuss? Obviously, a big one would be fatigue. Someone is certainly going to be fatigued if they're not producing enough red blood cells or not carrying enough oxygen. They're going to absolutely have a decrease in the level of oxygen in their bloodstream, so they're going to feel fatigue, right? We could have tissue hypoxia. Right, so we might have hypoxemia, which means we have a reduced oxygen load in the bloodstream, but also tissue hypoxia if the tissues are being denied oxygen for long periods of time. And then changes in pallor. So perhaps you'd have a change to the color of the skin, or the lips, the nail beds, the conjunctiva, and then there could be issues with respiratory function. You might have a change in the rate and depth of breathing to try to compensate for the fact that someone's oxygen carrying capacity has been diminished. Okay, so again, these are kind of general reasons, general things about anemia. Now we can break down a couple of different types of anemia. Okay, so when we're thinking about types of anemia, I'm going to start with some dietary issues, okay? The guided notes will give you fairly detailed information about all of these different types of anemia. I'm just going to kind of highlight them here now to supplement. So number 1, 2, 3. We're going to give you 3 examples of dietary anemia, okay? So the first one would be pernicious anemia. Second one has to do with folate deficiency. And the last one is IDA, which is iron deficiency anemia. Okay, and this is probably the most common anemia worldwide. So, different types of elements of the diet are required for the proper production, either perhaps of hemoglobin or perhaps of the cells globally. So because we have these dietary requirements, there could be issues where a patient's not getting enough of something in their diet, and that could be triggering the anemia. Okay, so first off, pernicious anemia is a deficiency in vitamin B12. Folate deficiency would be a reduction in folic acid. And then IDA is a decrease in dietary iron. Okay, so let's break down where these can come from. So very often pernicious anemia or decrease in B12 can be attributed to gastritis, whether it's an autoimmune or condition or patient has gastritis associated with something like alcohol intake. Okay, so when you have gastritis, you have inflammation of the lining of the stomach, and because of that, you may have an issue with transport of vitamin D into the circulatory system, and then, vitamin B12 into the circulatory system, and then because of that, you would have a deficiency overall in the level of B12. It is associated with many things, including alcohol intake, smoking, ingestion of hot tea, and the use of PPIs. So let me just talk about what a PPI is very quickly. PPI is a proton pump inhibitor. On the street, we call these acid reducers. An example, commercial example would be Prilosec is a PPI. So many people take these for acid reflux, but they have been linked, long-term usage of them has been linked to gastritis. And so again, when you have anything connected to triggering gastritis, it could lead to potentially a decrease in the level of B12 in the circulatory system. Okay, so that's pernicious anemia. Treatment obviously would be to give B12, which can be given via injection. Okay, typically with dietary anemias, and I'm being very general, if you supplement back what's missing from the diet, it can take anywhere from about 4 to 6 weeks for levels to stabilize in the bloodstream and to have relief of symptoms. Okay, so the second one would be a decrease in folates. That can cause anemia. So specifically a decrease in folic acid. Because folic acid is required, is needed for RNA and DNA synthesis, and we need to make cells, and we need cells production to be continuous. If you have a decrease in the level of folic acid, it potentially could compromise the ability for new cells to be produced, okay? This usually occurs in people who are A, alcoholics, or B, in people who are chronically malnourished. We are dependent on intake. So we are dependent on intake of folic acid from diet to meet the needs of RNA and DNA synthesis. The symptoms are going to be similar, signs and symptoms will be similar to pernicious anemia, okay, except that people who have a decrease in folate and folic acid would develop kind of fissures in the cheek and through the mouth, which you can understand because those are areas that are subject to fairly high abrasion that need continual cell turnover in order to maintain the lining of your oral cavity. So some people get ulcerations in the buccal mucosa. Okay, the last type is IDA. So IDA is iron deficiency anemia. So this is a decrease in iron in the diet. Again, dietary anemias, we're going to hopefully be able to have stabilization of blood levels. It takes about 4 to 6 weeks for these, each of these, when you give back whatever is missing, for them to self-correct. Okay, this is the most common type of anemia worldwide, is IDA. Usually it's in people who simply are not getting enough iron in the diet, so areas of the world where perhaps iron intake is not appropriate because of malnourishment. So the other reason that someone might have iron deficiency anemia is blood loss. So this is common in women during menstruation, especially those that have a very heavy menstrual period might, it's called menorrhagia, might experience a little larger scale blood loss, and that could potentially set the stage for IDA to occur. Okay, other things that can trigger IDA would be any medication that is potentially linked to gastrointestinal bleeding, so things like NSAIDs, for example, or patients who have gastric bypasses because there's a decrease in the amount of absorption time because of the size of the gastric cavity. So the symptoms are going to be really similar for some of the other types of anemia that are listed in the guided notes, but you would have things like fatigue, weakness, change in pallor, etc. The treatment for this would be to give iron supplements, and obviously you want to rule out the source of any blood loss if there's some sort of gastrointestinal bleeding, for example. And again, numbers should normalize within about a month to 6 weeks of treatment with supplementary iron. Okay, so now I'm going to discuss a couple of examples of anemia where the red blood cells are normal, meaning the structure is fine. It's not a dietary issue that would cause like a decrease in cell production, etc. But we have an insufficient number of them for another reason that is not dietary. So something like aplastic anemia would be an example. Aplastic anemia is an issue at the level of the stem cell. So there's been some sort of damage to bone marrow. So we can imagine that there are certain things that would trigger aplastic anemia. It could be some exposure to something toxic. Radiation can cause aplastic anemia. Chemo and exposure to certain drugs can cause aplastic anemia. In this case, it's not so much the erythrocytes, but it's really those bone marrow, those stem cells that are compromised. And so that's going to compromise the production of the formed elements of blood. Obviously, in this case, you'd have to address what's causing the damage to the bone marrow in the first place, and then have an appropriate treatment depending on what's the root cause really is. Okay, another example is hemolytic anemia. And again, it's not so much that the erythrocytes are compromised. In the case of hemolytic anemia, the cells are being destroyed faster than they're being replaced. Okay, so destruction and breakdown of the red blood cells is greater than replacement. There's different types of hemolytic anemia. There's inherited hemolytic anemia, which is a congenital issue. And then there's acquired hemolytic anemia, which can be linked to certain autoimmune diseases, okay? So these are two different types of anemias that are related not so much to the structure, again, of that erythrocyte, but more about the production, right? They're structurally sound, but there's just not enough of them, okay? The opposite issue is when someone has polycythemia. So now in this case, it's not that we have too few, now it's overproduction. So you have too many red blood cells. Net, you want the amount to produce and the amount to broken down to be equal. But in some cases, you have too few, and that can result in types of anemia, or in this case, you have too many. Okay. When someone has polycythemia, it can be connected to certain things like COPD. You can imagine if the body is getting the signal that the patient is not getting enough oxygen, right, because they have an underlying condition, it would increase the production of red blood cells to try to match that so that perhaps you could grab more oxygen and restore oxygen levels to normal in the bloodstream. So this is a common thing connected to COPDs. Blood doping. When people inject themselves with erythropoietin, can trigger the overproduction of red blood cells, and because of that can develop polycythemia. It's called like absolute polycythemia because it's not related to a genetic condition. Okay. High altitude can trigger an increase in production. And then there's a genetic form of polycythemia called PV, polycythemia vera, which is a mutation of what's called the JAX2 gene. And what it disrupts is cell signaling that would stabilize the amount of red blood cells produced. That stabilization is gone, and so because of that, now you're overproducing red blood cells. So we can imagine a big danger with overproducing red blood cells for whatever reason is you're going to get an increase in viscosity of the blood. Viscosity is the thickness. If you increase viscosity of blood, you're increasing the thickness of the blood. Think maple syrup versus water. In doing this, you increase resistance to flow. And overall, what that will do is drive up blood pressure. Okay, so you would have an increase in blood volume, an increased blood pressure due to an increase in viscosity. Things you could identify is you would see an increased hematocrit, but what this can trigger by increasing pressure and thickness of blood, it can increase intracranial pressure. And an increase in intracranial pressure would trigger things like headaches or possibly visual disturbances if you're compressing the optic nerve, and could potentially trigger a seizure. The treatment for polycythemia is phlebotomy, is removal of whole blood. Okay, that's going to do it for disruption of red cell function. Next, we're going to talk about changes to iron, and then we'll go into white blood cells.